here we go.
Good morning, everyone. My name is Jane Matuli. I'm a PhD student at UMass, first year, second semester. I'd like to welcome you all to our third annual nursing PhD research symposium. And just to let you know that we have a panel of individuals who are going to be participating. We have students, and we also have previous students coming in. I want to take this opportunity to welcome Dr. Ray. She will be the first person speaking.
Good morning. My name is Ray Walker. I use they, them pronouns, and I am the director of the PhD program here at the Elaine Marib College of Nursing. And it's wonderful to see those of you who are here in the room with me, the Student Union Ballroom here at UMass Amherst, as well as all of you who are joining us online. I want to acknowledge that the University of UMass Amherst sits on land stolen from the Nonotuck and other neighboring nations, such as the Nipmuc Nation, who are still here. And it is my absolute honor to introduce this, the third annual student organized nursing PhD research symposium. This event is a labor of love, organized and led by the PhD students themselves, with support of faculty and some amazing staff like Ben Monat. And I want to express my gratitude now to the PhD Student Organizing Committee, including Executive Committee members, Dr. Emily Logden and Tegamea Mwalingo, PhD student members, and names are important, so I'm actually going to share all of them. Sangduan Gindao, Sherry Heron, Danielle Gould, Sarah Bridington, Corey Gattrall, Janine Blake, J.D. De Silva, Sabriye Aban, Pamela Masoka, Jane Matuli, Linda Young, Stephanie Kent, who's assisting with our interpretation, as well as Alex Terrell, who is helping with the live streaming today, Melissa Shetler from Alumni Relations, who's assisting us as well, and again, Ben Monat, who's been a support throughout this process. I also want to thank Dean of the Elaine Marib College of Nursing, Allison Vordestrasser, as well as Executive Associate Dean Cynthia Jassalon, who you'll hear from shortly, and all of the administrators, faculty, staff like Cynthia Mendoza, who assists the PhD students throughout so many the things they need to do here at the university, and other staff, and all without whom this would not be possible, including the staff who maintain this space. We have some very brief housekeeping, and I believe there are some visuals to accompany these. I want to make sure I display those so they're clear. Okay, all right. So again, the theme chosen by the students for this year's symposium is From Gaslighting to Growth, moving past resilience to support nurses as they heal. We do have continuing education credits available, and you can email Ben Monat here for more details about those. American Sign Language and live captioning are part of today's event, and please see Ben Monat again for more information about that. And we also thank Jamie here, who is assisting us presently. We have some disclosures that were put together by the students. These slides are available on the event website if you would like to read them. And finally, just to say a few words on the theme for this year's symposium, which again was selected by the students. Before I say that, I should mention on the front of acts of collective care, the PhD students, including Linda Young, were kind enough to curate some resources for students, faculty, staff, and community members to support wellness and well-being. And those curated resources are also available on the event website today. So today's theme was chosen from gaslighting to growth, moving past resilience to support nurses as they heal. And I love this theme because of all that it captures. And it brought to mind to me this image that I've been reflecting on a lot lately, taken by a nurse who's actually a faculty member of one of our current family member of one of our current PhD students at Lafayette Medical Center in Colorado, not very long ago. And what you see in this image is nurses, healthcare workers clad fully in PPE needed to care for patients, some of whom may be navigating COVID-19 at a under-resourced and overmaxed hospital in Colorado. Here they are staring out of the window at a nighttime scene. There's snow on the ground. They see an ambulance, a life flight helicopter there in front of them, and beyond on the horizon, an eerie orange glow. That eerie orange glow is a wildfire, an urban wildfire, one of the most destructive that has ever occurred here in the United States. And it was caused by a lightning strike that hit a very populated area. And because of a number of factors, including some associated with the current climate emergency, it was able to grow and spread quickly. So to put ourselves in the minds of these nurses, not that we can speak for them, you can imagine they are facing myriad challenges: understaffing, under-resourced, overmaxed capacity at a hospital brimming not only with all of the delayed care and urgent needs of folks trying to navigate health, but also COVID-19, facing climate change, facing an actual wildfire approaching their building right over the horizon. It's a lot. It would be a lot to handle under the best of circumstances. And certainly these are not the best of circumstances. And certainly the structures that led us to these circumstances have existed for a very, very, very long time, even before the pandemic itself struck. Nurses see it all, as well as those who are engaged in other labors of caregiving and nursing. We see it all. Collectively, we know there are significant challenges. We see what some of the root causes are, the structural and institutional and policy issues. And yet for generations, nurses have often also been told, ignore the evidence of your eyes and ears and your head and your heart. It's not that bad, or it's not really this problem, or it's not your place to solve, or stay in your lane. I think this theme the students have chosen, from gaslighting to growth, reflects a need to move beyond that current status quo that is not serving us, so many of us. And in nursing itself, nursing PhD programs focus on knowledge generation for the profession and contribute to improving health as well as social justice in so many ways. But in nursing too, we have a history of fostering some of these structures of oppression that need to be reckoned with. Whether that's features like capitalistic health systems that maximize profit at the expense of human suffering and nurses' suffering. Whether that's whiteness in the profession that has sidelined and erased the lived experiences of racialized nurses and so many who do not fit that mold. Whether it's ableism that has prevented disabled nurses, disabled community members from participating fully in getting care that integrates and recognizes their leadership. Transphobia, sexism, classism, and these hierarchies, even of educational degrees, that minimize or dismiss the importance of lived experience as valid expertise, of citizen science, of the everyday person's knowledge of their bodies, of their lives, of the structures they are navigating. All of these spaces are in need of growth and transformation. And today we have an opportunity to hear from an invited guest panel, from students and from others, to reflect on how we will build the worlds that we cannot live without, even as we dismantle the worlds we cannot live within, to quote Dr. Rua Benjamin. So thank you for being here. I have immense gratitude too to our panelists and guest speakers who are here today to share their wisdom and lived experiences with us. And with that, I'd like to introduce Executive Associate Dean Dr. Cynthia Jocelyn, former director of this program, to bring words of welcome.
Thank you, Dr. Walker, and good morning to all of you. It's nice to see you, and it's nice to see those of you who are online. I'm delighted to be here this morning. I'm standing in this morning for Dean Fordistress, who had a family emergency she needed to attend to. So she sends her regrets and her welcome to you as well. This is the third annual PhD Research Conference. And in that, it's now been long enough that we can actually call it annual. You know, when you have the first annual, you think, maybe there'll be a second. But we're now developing a tradition, and I'm so glad that you can all be here to participate in that tradition. I'll be joining you for most of the day on Zoom. I want to thank the planning committee, who has done a lot of work to bring you two really interesting panels this morning. Also, I want to thank those of you who agreed to speak as panels. And finally, all of you who have chosen to come and share your knowledge and expertise with us today. So I hope you have a wonderful day. And again, thank you very much for inviting me to welcome you this morning. So have a great day. Thanks. Thank you.
Thank you, Dr. Jocelyn. And now it is time to start the symposium. I want to invite Sherry Heron, one of the organizing committee members, to introduce the invited guest panel for this morning's discussion.
Thank you, Dr. Walker. Can you hear me? Okay. So my name is Sherilyn Heron. I'm a second-year PhD student here at the University of Massachusetts, and I'm very honored to be able to introduce our guests today, guest speakers. A couple are visiting online. So when I say their name, then maybe if they can give a wave so that everybody knows who they are. So we're going to start off. Oh, yes. And I'm the CEU lady. So if you have any questions about CEUs, just let me know. Okay, so I'm going to start off with Emily Lugden. Who's waving? Okay, Emily Lugden is currently a PhD candidate here at Elaine Merritt College of Nursing and is currently on active duty in Alaska as a U.S. Army family nurse practitioner. She has a background in emergency and forensic nursing. Her client population includes service members, veterans, and family members aging from neonates to older adults. Her research interests include stress, trauma, healing, individual and community wellness, and health behaviors.
Good morning. Thank you, Sherry, for that introduction. Is it possible to have my slide put up, just because I'm going to reference the figure on it, and I think it would be hard to describe verbally. Okay, and what's also on my slide is my disclosure that what I am saying is my opinion as a panelist. I do not represent the Army's position, the Department of Defense, or the US government. So my experience in nursing, especially over the last 6 months, has really enlightened to me the importance of nurse scientists to be a voice to inform healthcare leadership at all levels. And the hospital leadership typically in the Army always includes at least one nurse representative as part of the leadership. However, we all know that we are the majority of the workforce. And so the nurse scientists informing the hospital leadership really better captures the voice and what the clinical picture is for all of the nursing. And I'm not sure if people can see the slide, but the patient caring touch system underneath the star is the Centers for Nursing Science and Clinical Inquiry. The patient caring touch system was developed by General Horoho. She was the first nurse to be the Surgeon General of the Army. And it was developed to be similar to the magnet system in the civilian sector. So I do want to acknowledge that it is a model, it is a tool. So it was created by people who are not perfect, and it is an imperfect tool, then also used by imperfect people. However, in my experience, the units who use the patient caring touch system that includes the healthy work environments also do have healthier work environments. The units that I've been in who don't include the patient caring touch system as their model of care often have unhealthy work environments. So what I think is really important, there's a few things really important, a lot really important to this, but for today, I do want to speak on the healthy work environments that, of course, we deserve healthy work environments for ourselves, but it also is directly connected to person-centered care, and that's reflected in the center of the triangle. Also, that the Centers for Nursing Science and Clinical Inquiry being at the bottom, to me, really demonstrates that the nurse scientists are foundational to employing the patient-centered, patient caring touch system that includes healthy work environments, and that this is a large part of the model of care. So personally, I plan to include patient caring touch system and improve the clinic that I'm in to make sure that we are actively engaging and using this model of care. This will also reflect my interest in trauma-informed care, which also addresses the importance of having healthy work environments. And this concludes my talk. I look forward to any questions that anybody may have at the end of the panel, or any questions if anybody wants to reach out to me by email. Thank you very much.
Thank you, Emily. Oh, I'm still. Okay. The next speaker we have is Linda Young. And Linda Young, where is she? Linda Young is a second-year PhD student here at the University of Massachusetts and has 40 years experience in maternal child nursing. Her previous nursing experience included NICU, visiting nursing, school nursing, and teaching in AD and BSN programs. She is a nurse practitioner in primary care pediatrics and currently works in a developmental behavioral pediatric practice. Her work involves being a member of an interdisciplinary team caring for infants and children 2 months old to age 21. Her research includes childhood trauma, developmental outcomes in autism. Did you want to say a few words?
Hello, everyone. It's a privilege to be here and to share my experiences. As you heard, I have been here as I've been a nurse for a long time. And I will share with you, when I first graduated from nursing school, the mode of operation for nurses, especially with new members to the staff, was nurses eat their young. Right, we had the philosophy of approach to integrating new nurses into the work environment was you had to prove yourself, go through the tough times without a lot of support, and try to manage to develop your practice and your professional role wherever you landed. I am so grateful that that has shifted. It's not completely out of the arena of work environments. I appreciated Emily's focus on healthy work environments. I've had the opportunity to work in enough different environments that demonstrated poor and really healthy environments. Where I am now as a nurse practitioner with a wonderful group of colleagues and interdisciplinary professionals, we focus on wellness for each other. We gather every week, we discuss the clinical concerns, but we also do a gratitude check. And we provide support to one another for a variety of stressors that may bubble up professionally, in practice, or personal. So I really feel I have finally landed in an arena where I can flourish and really develop myself professionally. But it is critical, I have found, that the environment be supportive of that. Now, not all nurses have that benefit right now, and especially with all of the levels of stressors that are not only global, regional, but very much local, and they vary from region to region. My approach is to my research, really, it does focus on trauma and development, but we are all developing until we leave this journey on earth. And so just to remind everyone that we have the potential to make changes to inform our work environment, to be a voice that we press forward to the leadership level. My opinion is we need nurses at every single level of organizational structures, and a number of nurses lending their voices. And so I'm going to encourage the nursing body here at UMass Amherst to really be revolutionary and innovative in the approach to constructing those environments for ourselves. Have dialogue amongst one another, identify those pressures or stresses that can be modified, simplify practice so that there aren't so many hoops to jump through to justify your place at bedside or wherever you are in caring environments, and address those things, whether it be in written form to the CEO or to the CNO, or in conversation or in community, or public meetings within the organization. Please lend your voice. I have found that persistence makes for change. And I have had to be quite persistent in a number of my work environments to mitigate change. Nurses are wonderful change agents, but this gaslighting theme is so important because we get dismissed. Our voice isn't as valued. We aren't considered equal to those other much louder and more respected, empowered voices. But we have to rise up to that level, be a little bit more persistent and advocate for ourselves, not with hard press, but with science, data, and information that really speaks to how we can change how we practice, how we can improve our work environments, and how we can then become better at caring for and providing really good outcomes for the people that we care for. It's wonderful that I've had that opportunity through the years to experience successes in different ways. Some environments I've had to leave just because they weren't supportive and weren't in my line of philosophical approach to care. So that gaslighting theme, I think, is so appropriate right now, in terms of understanding where we are now, but where we can go. And, I think collectively, I always say this in my team, great brains make great work. And when we do this collectively and share respectfully ideas and be respectful in agreeing to disagree, but persist, don't give up, persist if you really feel that there's an issue to be addressed. And then we can move our practice arenas to a better place. I love being a nurse. I love being a lifelong learner. I will share, I've just turned 60 and I'm pursuing my PhD, and I am just really enjoying the academic setting and ability to learn from everyone that I interface with and to share my experiences and to grow as a scientist and nurse advocate. And that's my conclusion for my presentation today. Please feel free to reach out to me. I'm happy to support your path as a nurse professional, and in a supportive and very caring way. Thank you.
Thank you, Linda. We're still trying to figure out how to work with the microphone here. I know that you're probably hearing echoing. So one of the recommendations, Tegan may ask that we be close to the microphone when we speak, and maybe that will help. Okay. All right. Thank you, Linda and Emily. What they're saying is very apropos. We know that this is a very interesting time for nurses going through the pandemic, and that it may be one of the most important times for us as PhD students, as it's not just we're concentrating on students, but we may need to look beyond the students to start concentrating on nurses who are working in the field, because the numbers coming in on statistics is astounding about how many nurses are leaving the profession, how many are stressed, dealing with anxiety, dealing with depression. It's a very serious situation right now. So I think this is probably one of the most important times for us as nurses, as scholarly educated nurses, to start looking at the problems and hopefully resolving some of the issues so that we can continue to build our community and keep our community together. Our next speaker is Sabriye Aban. There she is. Okay. Sabriye is a PhD candidate here at the University of Massachusetts. She received her RN degree from Eshashir Azmangazi University. I'm sorry, I probably did not do justice to that, in Turkey, where she also served as faculty. Her clinical experience includes the Department of Chest Diseases, Surgery, Radiation Oncology, and in dermatology. Along with being a PhD candidate here at the university, she also teaches and works as a research assistant. Her research interests include public health, health promotion, youth tobacco prevention, obesity prevention, vulnerable population, chronic diseases, school nursing, public health nursing, and geriatric nursing research. Would you like to say a few words?
Thank you so much. I hope you can hear me, right? Okay, so I just want to do like quick correction. I was the clinical nurse in the Faculty of Medicine in Turkey. So I think, so I just want to add this one. And hi, and welcome everyone. I'm so excited and so honored to be here in the PhD symposium today. I'm from Turkey. I am the first generation in my family who seek higher education and out of my country. I'm a PhD candidate and it's my 4th year in the PhD program. Today, I will talk about from my experiences, how international students affected during the global pandemic crisis and what kind of resources they had. So during the global pandemic COVID-19 crisis, international students became one of the most vulnerable populations, and international students are missed from the vulnerable group list. And many international students harshly impacted by disease socially and economically because of their immigration status. In 2020, to stop the spread of the virus, public policies focused on medical intervention, creation of vaccine, emergency legislation such as social distancing, lockdowns, border closures. Universities shut down their campuses to address the health crisis. So during the difficult time, the governments provide emergency social and financial relief fund to many vulnerable populations. Unfortunately, international students considered as non-permanent residents are exempted from these government relief funds. So international students experience many challenging life circumstances, including the financial crisis. So measures like lockdowns and campus shutdowns are more likely to throw international students into severe state of anxiety, as many of them likely experience social and psychological distress, including emotional distress, impaired sense of personal self-worth, loss of interpersonal contacts, and impaired academic performance. So I would like to give you an example from the published research in 2020. The researcher talked over the phone with the international students about their emotional and financial distress during the pandemic. One of the students from Africa shared his experience this way. Our university was unexpectedly shut down in mid-March, at a time when we weren't prepared. With no money on me, I'm starving, I panic and experience anxiety every day. And another student also shared her frustration this way. After the lockdown, I couldn't travel home to Ghana. I reached out to my relatives to send me money, but international money transfer had been very slow during the pandemic. Every day, I go hungry and stressed. So findings of this research highlights that overall international students experience more stressor than the local students, and international students have suffered COVID-19 stress, which is associated with increased anxiety and depression. So in 2020, international human rights law made clear that while national governments are taking reasonable measures to safeguard public health risks, the measures must not discriminate against international social work, including international students and refugees. So it has been very difficult adjustment for everyone during the COVID-19 pandemic. So it's altered our way of life. For international students, it's already challenging to adapt new country, new environment, new culture, new campus. And during the worldwide pandemic, these bring unique challenges for the international students. So in addition to these challenges, the loss and grief experienced due to the loss of the loved ones because of COVID-19 and social distancing, travel restrictions have particularly impacted international students who may wish to see and visit loved ones outside of the United States, and it affected their ability to return to campus. So we all experience the stress, anxiety, isolation, being vulnerable during these difficult times. So how I handle these challenging times? I can say that I was one of the lucky ones that I surrounded by caring people in my school. First of all, our PhD coordinator, Dr. Rachel Walker, reached out to everyone in our program, offer help, provide resources, including emergency relief fund, provide us extra time, extra couple hours to help us, to talk with us if you are facing any challenges during the difficult time of crisis. And my advisor, Dr. Jahun Chang, helped me during my most challenging times in my life, provide me full support, provide me scholarship to the 12-week dissertation success program in the National Center for Faculty Development and Diversity program to help me and support my research study. Another one, American Rescue Plan, was approved by the Congress, includes support for higher education by expanding the Higher Education Emergency Relief Fund. So my university, UMass Amherst, provide all graduate students relief fund who are facing financial hardship during this crisis, including the international students. So there are many more other resources that our university provide for our students and UMass Amherst. So we include all the resources in our websites under the resources section. So including resources, difficulty transitioning to university life, academic help, financial struggles, healthcare, employment, stress relief, and even food pantry, and many more. Please check out our website for more resources that have been offered to the students during these difficult times. So I'm very thankful to be here, very grateful for the support that I received during the most challenging times in our lives. Thank you. Thank you so much for everyone for being here today.
Thank you, Sabriye. We're grateful that you're here too. And again, it brings up another question about what is the role as educators and PhD students or doctoral nurses with building the internal locus of our students that are coming through the university today so that they are prepared to deal more with the stressors with going into the hospitals or institution. Okay, so our last speaker is Jasmine De Silva. Jasmine, or she goes by the name JD, is also a PhD student here at the university and has her master's degree in science. She has been a nurse for 4 years and works in psychiatric mental health nursing. Her interests are nursing suicide and nurses with psychiatric illness. It's very apropos for today. And when she's not working, she enjoys time with her 8-year-old daughter. So thank you for being here. You want a few words, Jasmine?
Can everyone hear me okay? Excellent. So, welcome everyone. Thank you for having me here. I'm so excited to be here and talk about what I love. So I just kind of wanted to start this with a story because this is lived experience. And the story, I guess my story, I mean, I'm 28 years old, but I feel my story really only started about 7 years ago. And there was this night that there's this Jewel song. Funny to bring her up right now, but there's this Jewel song where she says, my favorite quote, and probably one of the quotes that I've always really related to is, she says, half alive, but I feel mostly dead. And that's just something that I had felt for so long. And 7 years ago, I woke up and I was kind of in a stupor. So I guess I didn't really wake up, but I could hear everything that was going on around me and I could feel everything that was going on around me. And I could feel my heartbeat, and it was every 2 to 3 seconds, where it's normally, every second you hear your heartbeat. And I remember falling back asleep, and I woke up in the hospital, and it was the first time I really had to face myself and what I had done, because that day, back in 2015, I had attempted to take my life. And I was very lucky to survive what had happened to me. And I was very lucky to be able to hold my daughter again, because she was only about a year old at the time. And I guess that's where my journey began, because when I ended up in the hospital, I met a nurse, and I told her, I said, I had been thinking about going to nursing school. And she looked at me and she's like, Jasmine, if you can survive this, you can survive anything. Like, do it, go to nursing school. And so I went home and I started back in my program that I was already in for an associate's degree. And I worked really hard to get into nursing school, and I got into nursing school, and I failed my first 2 tests. And I thought I was going to drop out. And I had another wonderful, amazing woman, Professor Sergio, who convinced me to stay in the program. And I did stay in the program. And I ended up graduating with my associate degree in nursing. And then I went on to my bachelor's degree in nursing, and then on to my master's, and now to my PhD. And what I find so interesting is, as I've gone through this period of time and I've worked in psychiatric mental health nursing, and I've supported all these people who have mental health diagnoses, I've really lacked in people supporting me. And I think that that is a systemic problem that's going on in the United States, where there's nurses who have mental illnesses and they're not given the resources or the tools they need. So when we talk about resilience, you know, the dictionary says it's the capacity to overcome difficulties, toughness. And while I believe that's true and there's some skill to resilience, there's also these external factors. And I always think about if I'm driving in a car and I have my windows down and it's beautiful out, and then all of a sudden it starts raining. Well, you could be resilient and you could use your skills and you could roll up the windows, but what if it didn't rain? And for me, that's something in my career that I really hope to address and work towards. I mean, nursing suicide has just recently been addressed in the last couple of years. We really focused heavily on physician suicide, as we should, because one death from anybody, I don't care what profession you're in or what you do for a living, is one too many for me. But we started focusing on nursing suicide, and we found that all these nurses that are taking their lives have problems at work. They have depression, getting treated by the PCPs, but undertreated, obviously, if they ended up taking their own lives. And so as I think about my career and what I want to do with my life, I just think about looking at those external factors. And I really encourage everybody, no matter if you're a nurse with a mental illness, you know a nurse with a mental illness, or just being a nurse in general, I think it's important to look at what we are doing or what we're not doing for these people that really need our help, especially in the middle of a pandemic. And we know statistically that nurses commit suicide more often during pandemics and past pandemics. And soon we're going to be looking at the research for COVID-19. And I just don't think facilities are doing enough to help nurses and help us care for people, you know, because you can't pour from an empty cup. And that's the phrase that I always preach to everybody, that you really got to take care of yourself. And I just hope that in the future, when we look at resilience, we look at taking away those external factors and not just our ability to be tough and to overcome difficulties. So that's it for today. Thank you so much, everyone.
Wow, thank you so much for sharing that beautiful story, and just knowing you have your support team here within the nursing graduate program. We're here for you and whatever you need to support to get you through this program, because your voice is so important. Okay, so we just have a few minutes for questions. I believe it's about 7 minutes. This is the time if people want to ask online or here in the audience, please feel free to put your hand up to ask for a question.
Hi all. I don't want to jump over anybody. Did anybody have any other questions come to them? I did have one come to me, but I wanted to let other people have a chance if they had a question come to them. I'll wait for just a minute. All right. In the spirit of time, a question I can start to touch on. This is an excellent question. I'm not sure who asked it, but I feel like I could speak for hours on this. So I'll just speak to it briefly. The question was, what best practices can we take from the standards of care in the military sector regarding nursing integration and decision-making for the systems currently in place in the US healthcare systems, and what are some barriers and considerations we need to consider? Of course, as Dr. Walker mentioned, that it is a capitalistic system that we're working in. And unfortunately, the military is kind of moving in that direction. So that that system does, of course, have a lot of barriers. As far as the military structure, one thing that I really like is these centers of nursing science and clinical inquiry, them being out external to the leadership, informing the leadership. And if hospitals having external bodies that provide evidence-based practice that we should be bringing to the bedside, and research that should either be being conducted or, again, being translated to the bedside, I think is really important. In my experience, when we have that external voice outside of the leadership who is making the decisions, it is more transparent and less focused about promotion, less focused about profit, and more focused on person-centered care, which can ultimately, of course, translate to better quality, safer care that I feel like we all know to be true as nurses, but demonstrating that to leadership can be a challenge. So I would be happy to go more in depth. So if anybody wants to email me, I think the link has been put up in Zoom that links to our bios that has my email address.
Thank you, Emily. There's actually a few questions that have come up, if you don't mind.
I don't mind answering the gaslighting question. I think it's important to understand how that relates to what we live and experience as in our practice profession. You know, I was looking at, as I was preparing for this, I was looking through many different, you know, meanings of what gaslighting is and how it can present. And what I found is that it's really having an organization or a level of individuals that sort of press against what you know to be true, or to suggest that your living reality isn't really what you're living, not hearing your voice, and then expecting you just to press on anyway, or to manage within their structure or construct versus listening and validating what is actually happening. And this is pervasive across all environments, and it has to do with the structures in place that we have to interface with. So I think it's important for nurses not to gaslight one another, and that those in practice settings hear and listen to the concerns of each and every individual. I so appreciate JD and Sabre's and Emily's presentation today, because I think it's nurse supporting nurses is a key place to begin. And that is in every single clinical or leadership setting that nurses exist, that we honor and respect each other's thoughts, opinions, and concerns, and validate them versus gaslight them and just say, tough it out, you've got to do it. I think of that picture with the nurses watching that fire under the conditions of pandemic care, and just hearing the organization say, tough it out, you don't have enough PPE, this is how you're going to work it out. And you know it was not safe. You know it wasn't good infection control practice, but yet you had to proceed anyway without the level of support you needed to really feel comfortable and safe in that work environment. Again, I'm in a hospital, there's a fire just down the road. That might be my neighborhood, yet I'm having to work because they won't let me go home because I'm needed because of the pandemic. So there's where gaslighting happens. And again, it's pervasive. You don't always recognize it. When you're feeling uncomfortable or instinctively you're like, this isn't right, this isn't good, they're not really hearing us, then pursue and persist. I have been able to affect change by persisting up for a very long time on the same concern, and then eventually we make progress. In particular, my work environment now, I have a lot more voice and influence. I began my PhD to have even more of a voice to deal with the colleagues at the medical level, What I'm finding is they're listening more, which is unfortunate. My voice was pretty loud before, but now that I've got this cred for PhD work, they're sort of, paying more attention and making change. But we are all responsible for helping one another and supporting each other's growth and validating each other's concerns. It begins with nurse to nurse, I think, and then we move change at the different organizational structural levels that we have to work within. So that's gaslighting. And wellness. As I was searching for wellness resources, oh my goodness, it's blooming everywhere. All the organizations that touch or interface with nurses are addressing nurse wellness. So that resource list that's posted, take a look at them because they have all kinds of wonderful self-care ideas and methods to help improve the work environment and to address nurse wellness. So I want, that's a resource that I hope you kind of take a look at and work with. Thanks.
Thank you so much, Linda. And I want to take an opportunity to thank you all for being a part of this panel. And it was really an honor and pleasure to listen to you and to share in your experience and your wisdom. So if we can give them a round of applause. Okay, and now we're going to have a short break. Thank you. Okay, well, welcome back and thank you for attending this morning's discussion. We are going to have now the second discussion, and Jane Matuli is going to be the moderator. This is the session, if you're interested in getting CEUs, that this one would be the one you would fill out the evaluation on and send it to Ben. Okay. All right. So without further ado, here's Jane.
Good morning again. My name is Jane Matuli, PhD student here at UMass first year. I would like to take this opportunity to thank the first group that has just completed their morning talk. And now I'm going to swing on to the guest panel. And here we have 5 guests that are going to be speaking. However, not everyone is here present, but I will start with someone that is online. And then as we go along, you will see who is here and who is online. So I would like to start with Patrick McMurray. I will give a little bio on him. Patrick McMurray is a second-generation nurse working in a pre-surgery care center at the University of North Carolina Medical Center in Chapel Hill. He's primarily clinical background is adult cardiovascular care. Patrick entered into nursing via associate degree in nursing pathway at Robinson Community College in 2013, where he now works as an adjunct faculty teaching pharmacology. Patrick is currently completing his capstone for the Masters of Science in Nursing with a focus in nursing education at Western Governors University. Patrick's interests include community college, nursing education, decolonizing nursing, symptom science, and citizen science. Patrick will be starting his PhD in nursing in the fall 2022. And I am going to go ahead and welcome Patrick McMurray to the panel. So Patrick, welcome.
Thank you very much. I'm so thankful and happy to be here. I hope everyone can hear me well. I wanted to kind of talk about a little bit today about how gaslighting happens from the standpoint of educational equity in nursing, and how that gaslighting translates from education to practice to research. Something that we've seen during the pandemic is that we kind of need all the hands on deck. And as someone who is currently practicing in a clinical area, in a hospital setting and in a clinic setting as well, what we found is that we need everyone. We've had to come up with very creative ways of being able to take care of people and handle surges. and deal with the staffing crisis that's been ongoing and been exacerbated during the pandemic. Some of the gaslighting that we see when it comes to educational equity, or when we talk about the preparation, the entry points that people use to enter nursing. Mostly what I'm talking about are the associate degree nursing pathway and the practical nursing pathway, most often found at community colleges, but that can also be found embedded within universities or technical schools. This has been a big area, a big topic for me, in that we found that there is always nurses who start off via these pathways, via the associate degree, via practical nursing programs, have been often mischaracterized. And some people tend to look at me very funny when I say that. And they think that I am supporting an anti-education standpoint, but I've always been an advocate for education, and I believe that it's possible for us to promote nursing education and nurses continuing their education without demeaning the pathways that many people, particularly people who come from impoverished backgrounds, people who are from an ethnic and minoritized populations, depend on these pathways. Community college education in order to enter nursing, whether they enter nursing program in a community college or they use community college to be able to pursue a bachelor's degree later at a university. So one of the biggest things we see is that this mischaracterization kind of is partly our fault. And we've seen this spill into society in that in February 2021, we had a state representative in New Hampshire, Linda Tanner, who made very disparaging comments about the ability of community college educated nurses to work as school nurses. More recently, we have a big blog called Talk 32 Me, who blamed the fact that there were anti-vax nurses on the fact that there were nurses that only had a 2-year degree. So what we've seen is that this idea that associate degree prepared nurses and LPNs are less than, that has kind of been perpetuated within side of nursing, it has spread out to the community. And that's harmful for a number of reasons, because as I stated earlier, we know that nurses who look like me depend heavily on these entry points as launching pads into nursing. We know that nurses who are particularly Black nurses like myself, who enter nursing via the associate degree pathway or LPN pathway, are more likely to continue on to continue their education to the BSN level and higher than their white counterparts. But we have people who are actively advocating for the ending and exclusion of associate degree prepared nurses and associate degree programs, and as well as practical nursing programs. Now, when we see that translate to practice, is what happens when these people graduate is that the gaslighting continues. They're kind of told that they're less than, they need to go get their BSN. And again, I think that there are healthier ways and more less violent ways to do this. But what we see is that there have been the development of very restrictive hiring policies, where there's BSN preferential hiring policies, even for new graduate nurses. Despite the fact that a new graduate nurse, regardless if they have a new graduate registered nurse, if they have an associate's degree or a bachelor's degree, requires the same amount of orientation, requires the same amount of support. And that continues on when we see disparities as to where we see nurses of color practicing. We tend to see a lot less nurses of color in critical care and specialty care areas. And that translates again to some of these issues that we're finding with these hierarchical systems of thinking that we have in nursing. Beyond that, when it comes to research, we think about how do these nurses who have an associate's degree or a practical nursing diploma, how are they involved in research development? Well, the reality is that there isn't much research that is focused on how they contribute towards society and to their communities, despite the fact that, you know, these nurses are working in the community as home health nurses in long-term care, in clinics. We are told that associate degree prepared nurses and practical nurses are not trained or not qualified to work in public health spaces, that they're not qualified as leaders, that they're not professional nurses because they do not have a baccalaureate degree. But the reality is that this United States has been very heavily dependent on its nursing workforce, because it's historically it's come primarily from community college educated nurses. And what we found is that we wouldn't have the workforce we had without them, and that moving forward, we can't move forward without these nurses being included. And it kind of bridges to my next point about how do we move forward from the nursing research standpoint. because we are talking about how this pandemic has impacted nursing practice and nursing education and the communities that we're working with. But we need to remember that the best people to talk about these issues are the people who are living through them at the moment. And so another big proponent of my interests is citizen science. And citizen science offers us a very unique opportunity in that it allows us to share the role of being a researcher and a scientist with the community, whether that is nurses who have an associate's degree or a practical nursing diploma, or whether it's people who don't have a nursing degree at all. When we're asking questions about how people feel about nurses in their community or some aspect of nursing practice or education, citizen science, which is essentially, and at its simplest point, the participation of the public in scientific inquiry. It has different levels of interaction that includes anything as basic as crowdsourcing and using citizens as sensors, and all the way up to extreme citizen science where it's complete collaboration with a trained or professional scientist with people in the community, regardless of their educational or academic qualifications. And so what we see is that citizen science has this big potential because a quote that Dr. Karen Cooper, who is a big advocate of citizen science here in my state of North Carolina, says that what happens for so long, science has been done behind closed doors. And with science, you're either all in or you're all out. There is no in between. There is no support if you don't have the ability to access a career in science. And that's woefully insufficient. So with citizen science, it gives us an opportunity to invite everyone into science and to help associate degree nurses and practical nurses see themselves as scholars as well. So I'll end there.
Thank you very much, Patrick, for your message this morning. I want to say something about what you just said, that you feel like, ADONs, nursing or student nursing who have not gotten their degrees in as a BSN may not be valued in society. But I also want to say that I have dealt a lot with ADN students in the past couple of years by being a clinical instructor. And I have seen that they do have desires to move forward because they also want to experience what other nurses are experiencing who are beyond their practice. As you all know, when the pandemic came into place, I didn't see much of a difference between a nurse who had a LPN, just an associate degree, or a BSN. We all jumped in and we all did what we needed to do, and society has been recognized. They did not look at you as if you did not have a BSN. We were looked at as a nurse because we all made a difference. And I want to say nurses are nurses. Okay, I want to jump on to the next person now in our panel is Ellen Smithline, and she is in front of us here today. I would like to introduce her to us this morning. Ellen Smithline pronounces she, her, and hers. She's the director of the nursing for clinical and support options, including Friends of the Homeless program. She's a recent graduate of the UMass Amherst College of Nursing PhD program. She has been a nurse for 35 years, sorry about that, including 25 years as an emergency nurse. Her research interests include her dissertation, factors that influence the decision-making process of the emergency nurse, sexual health, eye tracking, professional introduction, and identifying barriers to prevention, care, isolation, and treatment for the unhoused population exposed or diagnosed with COVID-19. She's currently developing a new nursing presence with the largest shelter in Western Massachusetts. Her years at UMass, also known as her crisis or midlife crisis, have been rewarding as she participated in the College of Nursing many opportunities. She was recognized as a UMass College of Nursing PhD Excellence in Service Award, UMass Amherst student graduation commencement speaker, and Johnson & Johnson top 10 nurses pioneering innovative COVID-19 solutions. She has presented at local, national, and international conferences, and she is excited to be part of this nursing PhD research symposium. Ellen Smithline, welcome.
Thank you very much for this introduction and also for coming back. This is truly a full circle moment for me. I was part of the inaugural committee to start the PhD program symposium, and it's just thank you for the honor of being up here. I have been, as you heard, a nurse for many, many years, and I appreciate what Patrick had to say. Just as a comment, I am a diploma nurse. I graduated in 1985 as a diploma nurse, and I did not get my BSN until 2014. And guess what? I did research as a diploma nurse. I was an educator as a diploma nurse. Why? Because it doesn't matter what title you have. If you have a question, you have the knowledge, the tools, and the ability to find resources to answer those questions. So thank you, Patrick. I really appreciate it. And yes, a nurse is a nurse, especially in the pandemic. I didn't care what title you had. If you were here with me in the COVID tent, taking care of the unhoused who were diagnosed with or exposed to COVID-19, you were there by my side, and I valued you no matter what. What did I do now? Well, my research is on perseverance. That's what it ended up being. It was perseverance of the emergency triage nurse. And with that came so many realities. As a nurse, and it's not just emergency nursing, we are supposed to, multitask. We're supposed to have the situational awareness of what's going on. We are supposed to do this. We are the end all for all, right? But no one is taking care of us. And I believe this pandemic has finally shown us that this is the real problem here. We are always helping others, but we're not helping ourselves. And that has now kind of worn on all of us. And we all are getting a little bit of PTSD if I wear an N95 mask anymore, because we're expected to continue on. With the perseverance, I developed a new perseverance emergency triage nursing model. And with it, we have interpersonal skills. We have interpersonal relationships that either are going to make or break our day, right? We are looking at what we have in our toolbox to get us through the day, but also we're looking at who are we working with? Oh, I'm working with them. Oh, we are going to have a great day no matter what. Why? We're going to have humor. We're going to have teamwork. We're not going to have these individual silos working together. Organizational. How many of you have had to chart certain things because someone wants to get facts and figures, but it has nothing to do with us taking care of the individual? And I feel that organizational levels are creating this problem where we have to persevere despite not finding value in that at that moment. Emotional. We all have an emotional baggage that is going on with us. With the perseverance that we have, it's important for us to not just staff the place that we're working at, but also staff the needs of the nurse. And that is, how many times are we actually working, have a crisis, something that really hits home with us, and we need that moment to decompress. As nurses, we pride ourselves as badge. Well, yes, I had a patient die, but by God, I don't need any help for myself. I'm moving on. We need a staff where we can actually reflect before we return to our actual assignment or our position or our job. Why? Because it's going to get harder to keep returning again and again to these positions after seeing life and death crises. And then the temporal part of it. We have this temporal layer in the back of our minds, right? This tick-tock going on, saying that we have to get our job done quickly and efficiently, but there's no actual value about accuracy. We want to make sure that we are not just doing things quickly, efficiently, but also accurately. And it's important that we essentially have to slow down our positions. We have to slow down where we're working to develop these relationships with our patients, with the people we work with, but also allow us to give good care. I feel perseverance has become even harder. As a nurse, I pride myself on being able to touch the patient. As my professional introduction, I always shake the patient's hand because I want to know a connection, but also I'm also doing my assessment. I'm multitasking. With COVID, we were discouraged to do that. I can't be a nurse unless I can touch my patient. So that meant wearing the Tyvek suits, wearing the N95, the face shields, everything else. Why? Because no one was going to tell me how not to do my job. So by having this ability to still make those connections, even if it's through plastic, Tyvek, whatever, I thought it was important because isolation is creating this new barrier when it comes to giving care now. Isolation should never be part of a nursing care model. And we need to find out how to get through these barriers. How do we get through the barriers of COVID-19? How do we get through barriers of just being able to do our job? And lastly, I feel that it is important for nursing to have a voice. And unfortunately, we are working with organizations that enjoy profits. So I feel it's important that nurses are able to do our own billing. I feel it's important that we are able to provide the ability to bill our services just like physicians, radiology, and every other department. We should never be part of a facility charge. If we bill, that gives us a voice, not just locally at our hospitals, but it also gives us a voice state and national and international. We are seeing this now as they are trying to do a cap on salaries for traveling nurses. I think this is the time for us to really figure out how valuable we are and have people listen, because this is our time. This is our time for our voice to talk. Thank you.
Thank you very much, Ellen, for your wonderful talk this morning. I really appreciate everything that you've said. And I can really, really connect with your story because I have worked at the bedside during COVID, and you talked about separation or isolation. Of course, we were not supposed to be having that moment. We're given such a little time to be with the patients. However, I know what I did as a nurse. I spent my time with the patients. I geared up as I was supposed to gear up. However, you also know that we were not taught, we were not ready for the COVID-19. It's only instructions that were coming every single day as we were going into our assignments. Every time there was a new thing happening, oh, this is how you need to prepare yourself to take care of your patients. But you said one thing that was very striking, that we should not be taught how to do our nursing job because we have our own licenses. And when we go into the patient room, there is nobody watching us taking care of our patients. We are doing it on our own. We can be given 1,001 instructions, but you can choose to use whatever instructions you want. So having said all that, I would like to transition to Felicia Kramer. She's a clinical nurse. She pronounces her name as she, her, graduated from Thomas Jefferson University based at Medical Center with a degree in nurse midwifery in 2021. Prior to these, she worked as a labor and delivery postpartum recovery nurse, besides bedside nurse for 3 years with experience working with neonatal intensive care. She currently serves on the panel the Political Action Committee with the American College of Nurse Midwives. Felicia, I'd like to welcome you to this panel this morning. And she is actually online.
Hi, thanks for having me. I'll address the small elephant in the room. I have my 10-month-old with me, and she will probably just have to stay on the video, else it's going to be a lot of crying noise. I'm really happy to be here. I think that this is a really important topic for us to sit down and have a conversation about because, you know, I think a lot of times we're just not having these conversations and we're not talking to nurses and we're not, you know, really trying to get their lived experience. As a person who has worked primarily as a bedside nurse, so, you know, I haven't been a nurse near as long as most people in this panel. It's going on 5 years, and I have worked throughout this pandemic, and it has been just a very interesting experience in the sense where at the beginning it felt like nurses were heroes, and we've transitioned to this thing where we felt like we were heroes, but we weren't being treated in the way that heroes should be treated, and we weren't given the ability to care for ourselves and care for our families. And then in addition, you're caring for patients, but you're also trying to keep yourself safe, and you're trying to keep your family safe, and you're trying to work in an environment where you're not quite sure all of the, you know, all of the risks of this virus that you don't know that much about right now. And I think that our healthcare system, to be entirely honest, failed our nurses and failed our medical staff and failed everybody that was working in the hospital in many different roles, keeping us safe in a time that that's what people expected us to do. You know, I think as nurses come and are willing to work, but are also expecting our facilities to take care of us and keep us safe and give us the equipment that we have to keep us safe. And I think there has been a reckoning in the nursing field, as we can see by people leaving in droves and not staying and finding different opportunities or going somewhere where they're getting paid more. Like how many people are transitioning to travel nursing because they feel as if they are able to get paid. And we can see that the hospitals do have the money, and they will pay whenever people are demanding to be paid. And I think that it will be interesting to watch this grow and see how we change. You know, I think that the pandemic has highlighted aspects of healthcare that need to be worked on. And I think that in a good way that give this emphasis on healthcare, where people deserve healthcare, and the people working in healthcare in all aspects deserve to be treated well. And I think sorry, can you hear me now? Yeah, okay. So I think that the pandemic, in a way that nobody wants it to be, has highlighted and given us a platform in order to emphasize how important healthcare is for us. And I am going to just wrap this up now, and I will try to get her a little bit more settled for the next piece.
Thank you, Felicia, for your contribution. And I would like to move on to the next person. Our next guest is Nellie. Correct? Okay. She's a PhD student. She graduated from UMass here as a student. So I'd like to go back a little bit and talk about, give you a little bit about Nellie. She's a doctor, Dr. Mchenga. She's a registered nurse and midwife with a Bachelor of Science in Nursing and Midwifery from Kamuzu University of Health Science, previously known as Kamuzu College of Nursing, University of Malawi. She holds a PhD from University of Massachusetts and works with Fishburne State University. She's an assistant professor in the nursing department, and she teaches maternal newborn child nursing. Her research focuses on on adverse childhood experiences and how it affects health. Her most recent research project focuses on helping pre-nursing students develop resilience to enhance their transition to college and promote their well-being. She is a co-founder of Youthline organization, which aims at providing support and guidance among marginalized population. She believes that every individual deserves to be heard, seen, and understood. Nellie, welcome.
Good morning, everyone. I'm so excited to be here. This is such a great topic to talk about. So I would like to really talk about resilience and how we can support the nurses to heal. But I really want us to focus on how we can help the nursing body. The nursing workforce was already stretched prior to the beginning of the pandemic. And with this pandemic, the situation is now worse. And we have to start thinking about how we can help the nursing students to stay in the program, to develop the resilience that will help them to be successful once they graduate. So with this, because I really know that the nursing workforce as of now with this pandemic, it's been it's critical. We have shortage of nurses, and we want the young generation to aspire to join the nursing workforce. And we know that by 2030, most nurses who are working right now are going to retire. And who is going to really support the population? And also, as we are thinking about this, I want us also to really talk about how our nursing, how our nursing body is composed. As of now, we know that our nursing workforce that we have right now does not represent the population that we serve, which means we really have to also find ways of helping the young generation to join the nursing workforce. We want to focus on this young generation from the minority group. And these are the things I feel like these are the conversations that we should be discussing, and also talking about how we can support them. So like you've already heard, my research is focusing on adverse childhood experiences. We know that people of color, we know that minority groups have experienced trauma. They need support. So we are developing this program at my university, and I started it actually when I was here at UMass. I worked with Dr. Chandra, and this is a program called Strength-Based Intervention. And this is the program that I'm implementing it at my university. And the goal is really to diversify the nursing workforce, which we know that as of now, it does not represent the population that we are serving. So for now, I'll end there. Thank you.
Thank you very much, Nellie, for your talk this morning. I want to just add on something about, diversification in nursing. It's very important that we have diversity in nursing because we have to also look at who we serve as patients in the hospitals and many, many other healthcare places where we can possibly work. It's very, very important that if I am a person of a different, nature, it'll be nice to see another person of a different nature also serving there. That has also been my biggest thing too in the community. to encourage young men and women who are willing to go into the healthcare, mostly nursing. I mean, I don't know about medicine, but I also talk about nursing a lot because I am a nurse and I know that a lot of people can become nurses. I was never one of them, but I am a nurse. We are going to move on now to the next guest. And the next guest that we have here is Christine Schrav. Did I say right? Yes. Okay. Christine is she's an active member of the American Nurses Association, Massachusetts Health Policy Committee, committee, and actively participates in state legislative advocacy. Christine is also an adjunct faculty member at the Elms College here in Chicopee, in Massachusetts, where she teaches health policy and ethics to graduate nursing students. Dr. Sheriff, you're welcome to the talk.
Nice to be with you today. It's an honor to join you. Can you hear me? Okay. Oh, we have to go closer. Is this better? Okay. I'm a double graduate of this school, actually, my bachelor's and my master's, my clinical master's. And so it's wonderful to hear that the values that were here when I went to school are still here. Empathy with our patients, support of each other, community. These values are still here. And I'm so happy to hear that from all of the students. I'm here to tell you that there is a way to advocate for nurses through legislative advocacy. As you probably know, our license are granted by states. So each state grants our license, and they have rules and acts and laws that govern our practice. They govern what we can do. They govern how we're reimbursed. And so we need to advocate for ourselves, not only during the pandemic, especially during the pandemic, but all the time, in order that we can help ourselves and our patients. So I'm going to give you a little context just to start out. I work in Massachusetts and I live in Massachusetts, but the states are not that much different. So wherever you live, your state governs your practice to a certain degree. In Massachusetts, we have a 2-year legislative session. I am a member of the American Nurses Association affiliate here in Massachusetts and co-chair of the Health Policy Committee. And as such, we look at the bills that are proposed each year for passage or each session for passage. We look at them, decide which ones we really need to work on and advocate for or against to benefit ourselves and our patients. So we are in the second year here in Massachusetts of our session. As a committee, we develop testimony at public hearings, and here in Massachusetts, and believe it or not, we are the last state to open our state house. So I think it's opening today, actually, but it's been closed. So everything has been virtual, which actually is really beneficial for us here in Western Massachusetts because we're able to participate easily instead of driving into Boston. However, what we do is once we choose the bills that we're going to advocate for, we write and deliver testimony. We deliver verbal testimony at public hearings because every single bill has an opportunity for the public to give their opinion. And we also research the topic and deliver written testimony, and then advocate for that with the addition of our lobbyists. It's hard for all of us to participate on a daily level. We're all very busy. So most organizations have hired individuals who are expert at being at the State House or where they need to be in order to advocate for our cause. And so one of the messages I'd like to give you is that it's not possible to keep track of all this by ourselves. But one of the values that I learned was that it's very important for us to be a member, at least, of a professional nursing organization so that we can have access to what's going on of these laws and rules that affect our practice and know when things are heating up and when we can write a message to our legislator offering our opinion. They don't get a lot of people talking with them about issues, and we can advocate for our patients, for ourselves and our patients with our legislators. So anyway, we offer testimony, we continue to advocate, And eventually, some bills even get passed. One example is during the pandemic, and it was an awful thing, and it continues to be. Well, one thing that happened here in Massachusetts was nurse practitioners did not have independent practice. We still had to collaborate with physicians for prescriptive practice. So all states had emergency measures during the pandemic, and our governor, as one of his one of the directives, gave nurse practitioners temporary authority to practice independently. And so they proved that they could offer expert care, in some cases better care than physicians. And so at the end of the last legislative session, we finally, as part of a health omnibus bill, got independent practice because the pandemic allowed us to prove that nurse practitioners in Massachusetts could do that. So I'm just going to give you an example of 3 bills that we're advocating for in this session. If you want more information, please ask me, or Ben can give you my email information. The first bill is one that we've been working on for some time. It's a bill that originated from our group at ANA Mass, and it addresses nurse staffing. If you live in Massachusetts, you know that nurse staffing has been an issue here for many years. And it was actually a referendum in the state a few years ago. And even though that referendum, which called for patient-staff ratios, did not pass, it still continues to be an issue for nurses everywhere, especially now during the pandemic. But it still continues to be an issue here in Massachusetts. Our organization does not favor ratios as the best way to staff, but be as it may, it's still an issue for nurses. So we do have a bill that we have 2 legislators who proposed, one in the House and one in the Senate, to create a commission, a nursing commission with all of the stakeholders involved to really look at the evidence in our country and see what has produced the best patient outcomes. And so we really need to study this, especially now. And I will tell you that I write some of this testimony, and the pandemic has given us even more evidence about why things like this are necessary. And fortunately, some of our nursing colleagues throughout the country have published some of their experience so that we have some of that evidence to include in what we have to say. So there's a commission, and we're hoping that this bill will advance, especially now that the nursing shortage has made things even more critical here in Massachusetts, as well as throughout the country. The second bill is a bill that serves to set up violence prevention programs in healthcare institutions. That has been an issue in nursing for some time, especially now during the pandemic when people are so frustrated with the limitations we've been putting on them to visit their loved ones or their friends during the pandemic. There's been, and I'm sure you've seen in the media, there's been a lot of violence towards healthcare providers, especially nurses who are on the front line. And so there's a couple of bills out there. We like measures in both bills. So we've asked the legislature to consider coming up with a compromise bill incorporating some aspects of each bill into law. So that's one that's out there. The third one is incorporating Massachusetts into the Nurse Licensure Compact. And if you're not familiar, there is a compact throughout the United States where we can have multi-state license and make it easier for not only nurses in the military or families with nurses who are in the military, but also nurses to provide telemedicine services across state lines, a whole bunch of things. Just make it easier for nurses to go to other states where the need exists. And so we're hopeful that the pandemic has actually shown that this is even more critical now. And so that's one of the other bill that we're working on. So this is just 3 examples. There are other bills that we feel are important, but please keep in mind that we are the experts in nursing. Our legislators need to know about nursing from us because we know what works. And so if we don't tell them and we don't bug them like we sometimes do, to really pay attention to this stuff. Nobody else will. So that's pretty much what I have to say. Thank you.
Thank you very much, Christine, for your wonderful talk this morning. I'd like to say that Christine has really talked to very important points that will also help us make a difference in nursing. Not only during the pandemic did we need all these things, but we needed them all along, and we will need them for a long time. So I'll advocate for nurses. So please, if you're not registered, or if you're not part of the even your state nurses association, please do. And also for the American Nurses Association, because once you register for that, you actually become a member for the Nurses Association for the American and also your own state. So please do. It gives you an opportunity to actually get access to a lot of things that you might not know. It's only 2 years ago that I decided that I wanted to register, and it's very important that you get to see a lot of things. If you're in the education side or in clinical, you do have an opportunity to vent through some things that you can benefit from. Okay, so having said all that, I would like to say this time we're going to have some time to do questions and answers. So whether you're online or in person, you are welcome to participate in the question and answer session. So, okay.
I wasn't sure. Are we waiting for someone to ask? Because I know I was asked a question in the chat, so I don't know if I need to wait for.
I think we lost the volume to the main room.
Oh, okay.
I think that might be what's going on because
I'll wait for them to tell us they're ready.
yeah, I'll text them, somebody in the room, and let them know.
Sorry about that. We'll be continuing momentarily, please.
Okay, so sorry about the delay. So now we are going to start with the Q&A session. And we had some questions that were posted in the chat. So the first question we had was a question to Dr. Smith-Line. And the question reads, as you move nursing science into the homeless community, what are some key messages that should be considered as
we educate nurses to bring awareness to the minoritized population?
That's an excellent question. The first one that comes to mind would be stigmatization. So helping prevent that stigma that is associated with those who are unhoused. The epidemic is not just COVID-19. The results of COVID-19 and the moratorium has been lifted on evictions. We have had the highest numbers of homelessness or unhoused in the United States. You are just one crisis away from being in a shelter. We have people who are living in their cars, and we have people living in the streets, and we also have people living in our shelters. So know that this could be you. And so having that empathy that relates to that would be, provide just such great connection with the individuals. Also understand that addiction is actually a disorder. It is not just an addict. It's not someone who's abusing. It is someone who has a disorder. So by knowing how to address it medically, it's an alcohol disorder, it's a substance use disorder, will help us treat the patient as medical interventions as what they are needed and give them those wraparound services.
Okay, thank you very much for your response. If you feel like you need to ask more on that part, you're welcome to do so. So I will move on to the second question. The second question is geared towards Dr. Mchenga. And the question is, as we look at the exploration of diversity and inclusion initiatives in education, do you feel these are positions to make meaningful change? If no, what else should be done?
Yeah, thank you for a great question. Yeah, I think it is, it can make a meaningful change, but we have also to think about when we talk about diversity, we are just focusing on recruiting. Maybe we're just focusing on recruiting those students from minority background, but we also have to think about how we are going to support them when they get admitted to our colleges. And we also have to look at even our nursing faculty. When those students come, will they feel that they are being represented? Are there faculty members that they will feel comfortable talking to? Do you have things in place that will support those students to be successful in that program? Because what happens is we recruit those students from minority background, but when they come to the campus, they feel isolated and they are the ones who end up dropping. They might drop because of other reasons, because of isolation, and but also they might drop because of other challenges. They have already experienced trauma in their lives, and when they come, they need that support. And as a college, we need to develop ways of really including those students when they come. We need to put resources in place so that when they come, we can support them and they can become successful. So if we do that, then that's when the meaningful change is going to come. But unless we do that, it's not just recruiting them, but we need to put resources in place to support these students. And like I said, we need also the faculty of color that can represent these students, because this is also a challenge.
Dr. Mchenga, thank you very much for your response to that question. And it makes a whole more sense to have all the things available for the incoming students, because like you said, they have had challenges in their past. Maybe some people will tell you that I don't feel comfortable, I don't want to continue with the program. But if they're assured, I guess they can pick up and they will move on with the program. Okay, thank you very much. And I'd like to move on to question number 3. And this question is geared to Patrick. Patrick, could you speak to the ways in which defining the concept of gaslighting as an inter-nursing phenomenon may be preventing us from recognizing or addressing the power imbalances that exist within the healthcare system as a whole, particularly in nursing education?
Yes, definitely. I think that how this manifests a lot of times is that we see that I feel like a lot of times we use like nurses who enter through various pathways, particularly again the community college pathways, diploma, RN diploma, and LPN diploma programs, and associate degree programs as a scapegoat. Like they're like as if we, I say we because I include myself in that group, that as if we are holding the profession back. And often what we see the gaslighting specifically happening, the way it manifests is that we're told, okay, these nurses they don't think as critically as a BSN prepared nurse. And what that does, it kind of speaks to what Dr. Walker was speaking about earlier, and that some of the introductory comments in this symposium stated, is that it takes away the value of lived experience, because a lot of times what we see, particularly in community colleges, are second career people or people who have raised families and have children. And what it does is say that because they're not in a baccalaureate program, they're not going to be as good of a clear critical thinker. And it tries to relate critical thinking as only being able to be developed within a formalized educational program, when there's evidence to suggest otherwise. Critical thinking is something that we all develop in various different ways. There's not a singular way to develop critical thinking ability. And so it's kind of an insult to their intelligence to tell someone who has managed raising 3 kids making less than $40,000 a year and getting those 3 kids into college, that they're not a critical thinker, or they don't have as much critical thinking ability simply because they entered nursing through an associate degree pathway, or because they were a licensed practical nurse. So that's a very specific way that gaslighting happens within nursing. We also say things that, this label of professional nursing, and it creates a hierarchy, because professional at the end is someone who's a part of a profession, but we've made professional mean someone that has a baccalaureate degree or higher. So we're actually negating the actual definition of what it means to be a professional in order to say these things. And, kind of to speak to other things, we see the gaslighting, I'm someone who had to withdraw my membership from the American Nurses Association for a number of reasons. And a large reason is that it's very exclusive of LPNs. And I know that not everyone inside of the American Nursing Association supports that, and that there are people who would love to change that. But as of now, we claim to be the American Nurses Association, but we only really represent registered nurses. And, I know that there are policies. I don't paint this thing as that the ANA is evil by any means, but I think that there are some really important things. If we're talking about supporting nurses, we know that during this pandemic, LPNs have been reintroduced into acute care facilities to help care for the needs. And we question why they really were removed in the first place at all. But if we're going to advocate for all nurses, we have to include all nurses and to be able to be full members, to have places so that they can speak about their issues. A lot of LPNs are doing a lot of the heavy lifting when it comes to long-term care and community-based care, home health, but yet they go unrecognized and unable to have a voice in many of our nursing organizations. Now, we find that nursing organizations like the National Association of Hispanic Nurses, the National Black Nurses Association, and similar organizations allow LPN membership in those places. So I just think that we kind of need to refocus and think about, if we're going to all move forward together, we can't afford to leave any nurses behind, regardless of how they entered nursing. And we need to kind of end this idea of that because you have this degree, you're not qualified to do this thing, because people bring in experiences from actually working as a nurse and working with their communities. And they're doing a lot of, work there. Just the last comment I'll make is that, another thing that I see with Magnet, I think Magnet, the way it's been implemented in many organizations, leads to a lot of unpaid labor for nurses in order to be able to climb up the clinical ladder and things like that, when really we're not. And again, so we're advocating for nurses' time and their abilities to be valued, but we also expect for them to provide a lot of unpaid labor in order to promote this clinical ladder program, often associated with Magna, not exclusively. So there are some hospitals that do this better than others, but what we see a lot of times is that, again, it kind of gaslights. In order to move up, this is you can move up, but you have to put in all this work. And nurses are more often than not put in a lot of unpaid labor already because they are parents. They're taking care of their aging family members or ailing family members, people who are translators for people in their community, for people who speak English as a second language. Nurses are putting in a lot of unpaid labor across the board already. And so I think when we talk about systems that help promote nursing and promote nursing scholars, we have to realize that we need to create systems that adequately compensate them for that time. And so that that they're not the burden of making themselves resilient and moving past resilience is not put all on those nurses. And I'll end that there.
Thank you, Patrick, for your response. But I also have part two of this question, which is gaslighting a convenient way for those who hold power to deflect from the deeper issues of that power imbalance? And if so, how can we make to ensure we don't buy into that?
Yeah, I can speak to that briefly. Definitely, I think it's an evasion technique. It puts the onus on the nurses who, again, it kind of punishes people, again, from the standpoint of educational equity. It punishes someone because they couldn't afford or didn't have access to baccalaureate education initially. And the system we currently live in does that. And so gaslighting is like, oh, well, we giving you, you can get reimbursement for your degree from your employer. And again, we've had research that tells us that money is not the only reason why nurses have an issue, continuing their education past their LPN diploma, their RN diploma, or their associate's degree. There are a whole lot of factors. You can give somebody a complete free ride, but the systemic structures that are in place may make that hard. But we keep kind of like putting the onus on these nurses who say, we get mad when nurses say, I don't feel like I learned much in my RN to BSN program. And instead of doing internal evaluation and saying, if nurses are telling us that I don't find this transitional program as useful, how do we as educators, how do we as scholars need to adapt these programs so that these nurses find them, make them find these programs and this education meaningful, and that translates to a meaningful thing for them. There's no way to accommodate everything, but I think it's time to listen and stop putting the onus as if nurses are just not being lazy and not wanting to continue their education. There are a lot of barriers. There are a lot of issues people have. A lot of, particularly nurses who come from impoverished backgrounds, where they're the first generation nurse, and they're carrying the heaviest burden, economic burden for their families, and trying to help them navigate this pandemic, especially.
Thank you very much, Patrick, for your response to that question. Did you need?
I'm sitting here thinking as you're speaking about some very important things that have to do not just with the people who become nurses, but with the profession itself. And my question, I guess, is how would you feel if there were one entry level to nursing, and that would be the baccalaureate level? Because we've demonstrated over and over again that the more educated the nurse, the better the care that's provided. It's more holistic, it's more compassionate, it's more empathetic. I mean, all of the things that you're talking about, the gaslighting kind of interferes with. So I guess that's my question. We've struggled with this for years. It's not just the person. Yeah, it is. It's the person, because going back to school, if you're an LPN, you've got years and years of more study, more costs, more time. If there were one level, one way of getting into this profession, and that we've demonstrated, I think, over and over again, that it really is the more educated nurse. So, and I guess the other thing that's twirling around in my mind is readiness for a baccalaureate education. And you can get that readiness at a community college. We know that very well. They're excellent at remedial training and helping people. So regardless of what your cultural and social background is, I think we have the wherewithal, if people were to come together and try to coalesce around one idea, we've not been able to do that because we're trying to be very receptive to what people need and want. And that sometimes interferes with what the profession actually needs and what the people we take care of actually need. So I guess that's my question. If anybody up there can answer that. You seem to all be talking about the same, at least in what I'm getting from you is very focused. So.
I have a comment, but I want to make room for the other panelists in case anyone else wants to respond as well. So.
I mean, I don't know if you heard, Ellie was talking about how physical therapy developed over time and now at the doctorate level, I believe. Thank you for that comment. And, you know, I think all of our ideas about this evolve over time. One thing that I have felt over the years was that it was important for all nurses to have a baccalaureate degree. However, I think in the last 20 years or so, because I'm an older nurse, I've developed an appreciation for the fact that we need steps for nurses in order to advance their education. And the reason is because we have tremendous inequities in our society. We have inequities in many ways. And a lot of that inequity revolves around how much money and how many resources people have. And so I think that, you know, if people can enter the profession with an associate's degree and be a safe nurse and then get to work and be able to make a better salary so that then they can afford to go back and get a baccalaureate degree, I think that's fine, because the inequities in our society make that possible. And now with student loans so expensive, it makes it more impossible. So I think that what we would like to see perfectly is not what we have at present. And that's just my opinion.
I also have to agree. The inequities are there, especially when a lot of our second bachelor groups that are coming to place now, they have all this world experience, but also many of them have families. So in order for them to go and do a baccalaureate program, I feel there's somehow a social responsibility of providing childcare, of providing transportation, of providing financial support, because many of our students have jobs still, and having a job, having a family, and going to school full time is challenging, and it's making it even harder than it really needs to be. So by having those resources, the social support, I think that will allow us to help kind of change the inequities that are currently in our society.
Thank you very much for your contribution to that question. And I'm going to move on to question number 4 in this.
Oh, I had a quick response. I can keep it brief, but we can continue if we need to as well.
I apologize, Patrick. You can go on, please.
Yeah. So I wanted to to speak to a couple of things. You know, I think the idea of having everyone be on a singular entry level is a great idea. But in practicality, it doesn't make sense for our time. I hesitate to compare nursing to other professions because much like was noted that physical therapy doesn't have our history, and physical therapy doesn't necessarily have to show up for communities and patients to the extent and the way that nursing does. I think that actually there are other places who have successfully transitioned to a solely baccalaureate entry pathway for nursing. But some of those countries have things like, a universal healthcare system, things like that. Where we are in the time now, us closing the pathway, closing other pathways and going to a singular entry point would actually do more harm than good, particularly in rural areas like my state of North Carolina. There's been some research done by the University of North Carolina Shep Center, and they actually they did a study on what would happen with a move from baccalaureate nursing programs. And what we would find, it would devastate the state of North Carolina because it's a rural state, and nearly 70% of our nurses come from the associate degree pathway in community colleges. And again, they are doing the heavy lifting in North Carolina when it comes to community care. And so what I found is that we're actually fortified because we have so many different pathways. Some of the things that I think about, we look at things like medicine and physical therapy that have moved to a doctoral level. Think about how inaccessible those careers are to many people. The American Opportunity Center already tells us that a baccalaureate degree is very inaccessible to people who are first generation, people who come from impoverished backgrounds, people who come from rural areas already, outside of that's just across the board, not even specific to nursing. So I think our path forward at this time means keeping these multiple entry points into nursing in place and intact, and again, fortifying and supporting nurses as they move forward in meaningful ways. But right now, I think it would be absolutely detrimental. And right now, the BSN workforce could not sustain nursing at all, not even remotely. And I think that there's a history. There was a reason why the associate degree program, which Dr. Mildred Montauk wrote about, it was kind of what the first nursing education program that was developed out of evidence. And when it came into being in the late 50s, there's a reason why within 10 years, it became one of the dominant forms of nursing education, despite diploma programs and baccalaureate programs being in existence at the same time. And it has dominated nursing education as the primary entry pathway for a lot of people up until recent years in the last 4 to 5 years. So I think that allowing these pathways to remain intact actually makes us better, because it allows us to welcome our arms as to who can be a nurse and who can reasonably achieve that goal.
Thank you very much, Patrick, for your response to that question.
One of the things it does is create role confusion, lots of role confusion, because you have a nurse. You're saying a nurse is a nurse is a nurse. Well, baccalaureate and associate degree, they all take the same licensure exam. So on some level, yes, you can say that a nurse is a nurse. But now you've got the same nurse who probably does want to go on and do some research because they discover that there's something about this addiction problem. I see these people coming and I'm taking care of these people with addiction. Now I've got to go get more education because I'm not believable. I don't know how to go to the literature. I don't know how to state a problem that somebody can go ahead and study. So yeah, I mean, I understand that you want to be compassionate. You want to let everybody who can come into this profession. I also think that we need to think about the profession and the integrity of the profession. And so that's the only reason I asked that question. It's impossible to answer because I think we all hold on to ideas that we hold to be true. And so I appreciate your perspective. I know where you're coming from. Most people would say the same thing. In fact, the American Association of Colleges of Nursing continues to want to have these other entry levels, even though it puts the student, the graduate of each of these programs, whether it's LPN or ADN, it puts them at great talk about healthcare. I mean, childcare. Many of the people who come into these programs are already parents. And now they're dealing with another educational program that they need to find care for and money for. So, if we could make a decision, then you could put the supports in place so that people could enter at one level and come out with one degree and then move on with their life as they can. You want to say something?
I just wanted to make a brief comment. I graduated in 1962 from here, so I'm old. I've been a nurse for a long time. Well, that may be. That's not an argument for today. And I'd like to respond that in 1965 was when the American Nurses Association declared that a baccalaureate degree would be necessary for entry into the profession. 1965. Patrick, this argument has been going on for that long. We're not going to solve it today.
Yeah, I think that it's very true. I think that the fact that it's been that long should make us
They
question.
American Nurse Association never said baccalaureate. What they said was all nursing education take place in the mainstream of American education, which Mildred Montag, you mentioned that, was her doctorate. At that time, we needed nurses because we were in the midst of a war. It took 3 years for a diploma graduate to become licensed. It took only two. It took only two for an associate degree, but it was a technical program. They didn't do visiting nurse. I mean, that's just one example of what baccalaureates included at that time. So they never said baccalaureate. You will not find that anywhere. What you'll find is all nursing education be taking place in the mainstream of American education, which it was not. It was in diploma schools and hospitals.
Yeah, I'll respond briefly so we can continue on. But I think that this is an argument that's gone on for a long time, and I want to be very to frame this very correctly. Particularly, we need to look at the historical context and the racialized issues that were in that framed that time period of the 1950s and the 1960s, and the exclusiveness that kind of came out of all of this. And when we look at the historical pathways at the way of excluding who's been excluded when we make policies about who and who cannot be a nurse. We know that everyone may not want to be a nurse, or maybe everyone is not suited to be a nurse. But I do think that this ability, when we shut the door, we make the decision for a lot of people. And so I think that, yes, it's been an issue we've been debating for a long time. And I think it's time to start asking much different questions. The fact that we've been having this conversation since the 50s, and it's not happened yet, shows us that we've been asking the wrong questions and addressing the wrong issues when it comes to establishing the baccalaureate as a minimal degree. We see that we still have a need for multiple entry points into nursing, and particularly from a standpoint where we have studies that talk about the outcomes of nurses. A lot of those, that my personal scholarly critique of those is that they don't consider the socioeconomic and racial factors that are impact those statements and the assumptions that we make. So not saying that the studies were wrong or that they were insufficiently done, but I think that they missed a lot of the nuance about race and how these things have unfolded historically. So I'll end that comment there.
Thank you for that, Patrick.
Is everyone okay moving forward? I have a different question. I think we've heard a lot today from many of our panelists that there's a real sense of the importance and the urgency in this moment of time as nurses, where we feel like now is a time to really take a stand on our value and the importance of our profession. But as we've heard about today, we are facing so many crises. We heard about people talking about a need for mental health support, greater resilience. We've heard about staffing shortages. We heard about, gaslighting within our own profession, and, the fact that we're having to fight for higher salaries through travel nursing. So just a question for all panelists. And as Dr. Ashroff pointed out, we really have to pick our policies specifically and pick only a couple. So I'm curious what you guys think, if we were to choose one thing to kind of fight for and one thing to really draw to the center of attention, what would you think that it would be? And how can we as students and as a PhD program support that effort?
That's a great question. I think for me, with my passion, I would say that we need to focus on addressing issues related to diversity and inclusion in nursing workforce. So like I already said, the nursing workforce population doesn't represent the population that we serve. So what I would say for you as a nursing student is really to find ways, like when you're asking your questions or the research interests that you want to develop, I would encourage you to look at how you can support the underrepresented groups. How can you support them to, if we are looking at the young people, like how can you attract them to join nursing workforce, because that's what we need to address. We need to address the issues that people of color are facing. And I just attended this conference organized by Institute for Perinatal Quality Improvement, whereby we know that if you are a Black person, you are likely to die from pregnancy-related death, that you are three to four times likely to die from pregnancy-related death. That's a big issue that has to be addressed. But how can we address it? We need people of color, people from that group to join the nursing workforce. And also, when we are trying to really recruit these nurses from underrepresented groups, we also have to think about resources. That's what I have already talked about. We need to help them to develop resilience so that they can stay in the program, because just bringing them in the program, they are not going to stay if the environment is not conducive for them. So that's what I would encourage you to really think about and find ways to really expand our nursing workforce.
Thank you, Nellie. That's very important. As I think about this, I think about our society as a whole, and certainly our nursing workforce is the #1 problem to solve right now. I think equity in healthcare in our society is an issue. There are many things that affect healthcare and the health that people have, including social determinants of health. And because I'm a policy person, I think about policy that can advance that. And one bill I didn't mention was Senate Bill 1388. It's a bill proposed by Senator Joanne Comerford. Senator Comerford is my state senator in South Hadley. I'm not sure if she also represents Amherst. She does, Ellie says, yeah. But she has a bill out there that I have actually written personal testimony, and I got ANA Mass to endorse the bill also, that says that every policy or law that is considered in Massachusetts has to include the effects on health for the population that it serves. So every department, every law, every rule has to look at how does it affect health and the population it affects. If we could do that in our society, I think would be a long way towards making it more equal for everybody to have the better air, the better food, the better transportation, the better everything. And so health equity, I think, in our greater society is an issue.
Thank you very much. I'm going to move on now to question number 4. We still have a couple of questions to go through. So question number 4 is directed to Dr. Smithline. And the question is, while nurses have never been part of the room charge, is the answer to make nurses reliable or viable to make healthcare universal with no language changes, I believe it is? How do we increase nursing power without reinforcing inequitable systems?
I wish I could say I had the answer on that, and I don't. So I'm going to be honest on that. But I can make some suggestions, and that is the room charge can then be thoroughly categorized by nursing time versus bed versus stock, etc. I think by not necessarily increasing the charges, but actually itemizing them so it's showing what nursing had, the impact of nurses in that care. I think that would give us more equity and more the ability to be at the table where policy is being made. I remember being in one of our many PhD classes and hearing about the lack of representation when it comes to laws, policies, things like that. Luckily, we have, the ANA, we have Christine here to be our representative. But how many rules and laws have actually occurred without any nursing input? And that's not just federal, that's state, that's at your organization that you're working at. How many nurses are on the board? No one should ever make an impact in how nurses do what we do without having at least a nurse representing us and giving us a voice. So that's a roundabout way of answering that question.
Thank you very much for your response to that question. I'm going to move on to another question, which not necessarily, actually, this is not a question, it's a comment, and it's directed to Dr. Schwab. If you can post the bill numbers to facilitate enhanced communication with legislators. Okay, so thank you very much. We can do that. Okay, thank you very much. Okay, question number 6, I'm going to move on. This is a general question, and it's not necessarily for any one of us or any one of the panelists here. It could be anybody to respond to that question, but the question is, why do you think nurse administrators and hospital administrators engage in gaslighting nurses, even did this is the case in hospitals?
I'll make a comment. I'm not sure I have the answer. But I have been a nurse administrator in the past. So we live in a capitalistic society. That's one issue. And so even though many hospitals are not, most hospitals are nonprofit, they still compete. So the economic interests of the institution maybe not most important, but they certainly play a big role, I think. And so if you're in administration, you're between the devil and the deep blue sea, because you're between the staff that you care for and want to help, and you're between the administration that you've pledged to support. And a lot of those decisions that are made are economic ones. That's just my experience.
Yeah, and
I think one group we forgot to actually mention is the insurance companies. The insurance companies are really the ones that rule how we provide care within the United States. And the fact that they go kind of unnoticed at times with these discussions just tells us how well they're stealth-like. So I think we also need to address the insurance inequities that occur and how they're the ones that are making the policy, not necessarily the organizations.
Thank you very much for that. For next time, I think we'll be talking more about that. Okay. Okay, does anyone have a question? Okay, sorry, I didn't see that one. Patrick, you're welcome to continue with your response, please.
Yeah, and I just want to say, and also that the culture of healthcare, we've constantly told nurses that they are an expense and we don't generate money for health systems. And so I think it's changed the mindset. I feel like they can treat us in a certain way and gaslight us because, oh, you're an expense. So it's almost like the way that we've been positioned now, because we are a part of the room, we're just like a piece of furniture in the room, as others have spoken on, is that they kind of disdain nurses because, oh, I have to pay your money. They only view us as expenses. And because we don't bill directly, it's hard for us to track how nurses actually generate money and how nurses generate value for organizations. And I think that culture, because I've been told that the last 12 years I've been in healthcare, in the last 8.5 as a nurse, that I am an expense for the hospital. I don't generate outcomes. But we also know that if nurses weren't present in hospitals, the hospital could not charge, they couldn't provide care, so they wouldn't have an income. So it's kind of like there needs to be a cultural shift and stopping this almost hate of nurses. I don't think administrators hate nurses exactly, but this idea that nurses are only an expense and they don't see the value we do. And it's hard to capture the value that nurses bring, because we're attached to almost every aspect of acute based care and community care. So I think that cultural shift is needed as well.
Thank you very much for your response. And
Can I weigh in on that?
yes, please, you may.
I understand the financials with organizations. And we are a line item on the budget and usually seen as a cost savings measure. And I know there's research arguing for reduction in staff or, downsizing staff and then increasing staff on both sides. And so I think the nurse leaders and organizations, especially those at the C wing, are absolutely between a rock and a hard place when it comes to advocating for the needs of the nursing population working in the organization, and then fiscal responsibility. So my thinking on this is that we need to do some studies, base our argument about cost effectiveness on sound research, taking a real close look at the interventions and the outcomes and how we're able to be fiscally responsible and justify the staffing levels and resources that is needed to create those best outcomes, sort of balancing not only the science and care aspect of nursing, but the cost effectiveness of it as well, especially driving towards population health. Reducing readmission rates, improving health outcomes long-term, those kinds of research initiatives, I think will help to support our argument about our value. I don't know about billing per se for nursing. I think it's really tough to do. It's an interesting idea and an interesting thought. I know as a nurse practitioner, I bill for my services, and that way I can justify my value and my ability to get to population health outcomes. I wonder how we can do that within an organization for our phenomenal staff nurses and leadership in nursing in organizational structures. But a good topic to talk about.
Hi, I think I also, sorry, I'm just like now starting to be able to hear everybody. For some reason, I'm having a really, really hard time hearing everybody in the room. I can hear when people are talking on Zoom, but I'm not really able to hear most questions or most people's answers. So I think that, and I apologize now if someone has already said this, because again, I can't quite hear everybody, but I do think that one of maybe a reason that we can consider why people are gaslighting nurses is just the step away from actual bedside nursing, that the people that are actually making the decisions and sometimes making the policies have. So it can be easy to maybe even unintentionally gaslight people if you are not the one doing the bedside work, but you are the one making the policies and making the calls. And I wonder how we can kind of change our healthcare system or change how hospitals work, where we are asking the frontline workers and asking the people who are actually doing the work, their thoughts and their opinions and what they need in order to be able to thrive and survive in the nursing profession before we're making policy change, before we're changing, staffing issues, before we're adding, just like general things. So I just think that can potentially be one reason as to why people are getting gaslit, is just the big step away from actual bedside nursing and actually doing the work and making the policy change.
Thank you, Felicia, for your comment on that. Is there anyone else who would like to make a comment on any one of the questions or? Thank you.
The state of Massachusetts actually has just started a new behavioral care roadmap. In it, they are actually allowing nursing to bill. And it's called a CPT code of 99211. It's the first time we've been able to be acknowledged as at least financially an important part of the care of behavioral health. So I have hope that this hopefully will go into other organizations within care, both at hospital level and at community care levels, because I think it's an important way of, again, just giving us a voice. Thank you.
Thank you very much. And I want to thank everybody for participating in this. And I would like to welcome back Dr. Walker.
right, thank you so very much. I'm gonna try to do my best to project through the mask. Thank you all for the amazing panel, both now with our invited guests as well as our PhD and student speakers. Thank you, Jane and Sherry Heron, for your wonderful moderation of these panels, and to everyone here for being flexible as we continue to navigate this pandemic space of hybrid meetings in person and online, trying to be as accessible as possible, and yet also quite literally standing in a completely new room today, one that wasn't even built the last time most of us were here on campus. And part of why we're in this room today is actually because the original rooms we were supposed to be in flooded, unfortunately. So just so you know, the organizers, especially the student organizers, the staff, those assisting with the technical side today, have really had to be incredibly adaptable and flexible and worked very hard to make this the best experience they could under admittedly less than ideal circumstances. So thank you all again for your work. I have been asked to provide just a few words of wrap up and maybe to summarize some of the themes I heard today across our two panels and various speakers. First of all, with our student panel, I want to appreciate again the members of that panel moderated by Sherry Heron, Dr. Emily Lugden, who not only reflected on her own background and experiences of nursing in the military throughout this pandemic, but also the importance of resisting some of the corporatization that continues to occur within the profession, where nurses are not necessarily the ones being allowed to drive our own ship. Linda Young talking too about the importance of addressing structures in meaningful ways that truly support caregivers, nurses, and the patients and communities we accompany in care where they are. Sabrier, who brought up the incredibly important point of the precarity of international graduate students and international students generally throughout this pandemic, a precarity that existed before the pandemic, but was certainly exacerbated. And so for all of our international student body members, faculty, and alums, we are so appreciative that you chose to be a part of this community, and we so value your presence here and hope to continue to support you in that. And then JD, Jasmine De Silva, was talking about her own lived experiences and naming the reality of mental health impacts, not just of the pandemic, but of moral injury and other aspects of health and care and society, and the need that systems need to go beyond just expecting folks to be resilient, even as they are resilient and adaptable and working so very hard to continue to show up for patients, for each other, and for themselves. So thank you again to the student panel. I can't. And then for our panel, just now moderated by Jane Matuli. Thank you, Jane, for working in this command center. Again, I want to appreciate Patrick McMurray, who was on with us. I think he may have had to go because, of course, so many of our speakers are working nurses there at the bedside and out in the community, speaking to the importance of breaking down hierarchies, not just in healthcare, but also in nursing, regarding sort of who is a real nurse or a worthy nurse or a nurse leader with expertise to contribute. Some of the challenges of systems like Magnet, which do put unpaid mandates and burdens on nurses, even as they are supposedly designed to bring more of a nursing voice to systems, and naming that, the role of associations, not just ANA and our sort of larger professional associations, but also the National Association of Hispanic Nurses, the National Black Nurses Association, and others who have been incredibly inclusive and who continue to provide vitally important leadership. And I encourage you all to check out those organizations as you have the ability. They are doing wonderful work, as well as our sort of longstanding and legacy associations. I think you'll find too, those organizations have been around a really long time. And again, we want to make sure their expertise is centered. Dr. Ellen Smithline, thank you for being here in spite of running a clinic and so many of the hats you wear. Talking too about the fact that you did research as a diploma nurse, which is awesome and exactly what we might expect. So thank you for sharing that. And also some of these ideas around the fact that while nurses are asked to care for everyone, no one is caring for us, or at least it seems that way sometimes, the way systems have been designed. And also naming the reality of disparities like having the highest number of unhoused persons during this pandemic and stigma of serious health challenges like addiction, that these are human beings trying to navigate very complex systems and challenging situations, and not to be othered or dismissed for that labor. And also speaking to your perseverance model, the fact that systems must staff to the needs of the nurse and everyone in the system, not just the sort of minimum denominator, so that nurses and others can also pause in their labor, reflect when necessary, and grieve and have space to grieve and support each other. And two, the importance of nurses having voice in these systems. Felicia, thank you for juggling multiple hats today. We were delighted that your little one was able to share space with us. That's such a reality for so many of us. And mentioning too that we do so much caregiving, but facilities and institutions have also failed us because of what they have not done for us and the need to change that. And of course, Dr. Nellie Lewis-Machenga, we're honored to have you here as well. Your words about what we can do to address nursing workforce challenges, including the fact that faculty, members of the nursing workforce leadership should reflect the communities we accompany in care, that we should be paying attention to the next generation of nurses coming up, that we should be looking at how our systems currently bar or could do a better job supporting, inviting, and creating a welcoming and flourishing environment for minoritized, racialized, currently and historically excluded students who entered this space, so that we can truly deliver the best care for everyone. And Dr. Christine Schroff, who is a double alum of this college, thank you for reflecting on how you see values you heard back in your original time here, reflected in some of what you've heard today for your legislative advocacy at the level of the state and beyond, for your notes too about how some aspects of accessibility of participating in policy have improved in some ways during the pandemic, something we hope we don't lose, and the role of professional organizations like where you work with ANA Mass to bring forward important pieces of legislation. I put the links to that policy agenda in the chat for the Zoom, and we can certainly try to post those on the website if that's helpful. Notably, the three pieces you noted, the commission to study nurse staffing issues and what are sort of best practices in that space, violence prevention, a longstanding problem in the profession, and nursing licensure compact acts and changes, including expansion of the capacity to participate in telehealth. So thank you all for that really wonderful insight and expertise you brought today. This session should be archived. It's my understanding it will be posted and made accessible on the Elaine Marib College of Nursing website for others who may wish to watch or rewatch any of what was shared today. I'll note we're now reaching the end of the online portion of this program. Those who are here, there will be lunch offered for you to have a brief break. We encourage everyone, both online and here in person, to please check out the student posters. They are digital posters, so you can access them anytime. They're linked to the event website. That link is also in the chat, so you can check those out. It looks like someone just reposted that. Please do take a moment to see the labor of the students and the important work that they are doing. We have other resources, again, such as the wellness resources Linda mentioned, posted there as well. And finally, again, I cannot express enough gratitude to everyone who helped make today possible. Those of you attending here and online, including so many of our alums, our valued alumni, current and former students, faculty and staff who made all of this work, and especially Ben for his labor. Thank you, Ben. And again, Melissa Shetler, who's been helping with some of the tech as well and checking folks in. Thank you, Melissa. Thank you, Alex Terrell, who's helped with the live streaming. I'm looking at you now. And then, of course, and perhaps the ones that without which, you know, the seeds of this would not even have existed if it weren't for the students saying they wanted their own space to create a symposium and host this community to come together every year. So executive committee members, Emily Lugden and Tegamea Mwalingo. Dr. Lugden, double doctor. Luna, Sherry, Danielle, Sarah, Corey, Janine, Jasmine or JD, Sabrier, Pamela, Jane, Linda, and Stephanie. Thank you all again, student organizers of this event. Ben, did I miss anything? All right, Jane or Tekamea, did I miss anything? All right, those of you online, I'm just going to bring up the chat real quick to see. Okay, we've got links to everything, lots of love for each other. Thank you everyone who gave your questions. Again, continuing education credits are available. Just reach out to Ben if you want them. We wish you all a wonderful, safe, restorative rest of your week, and we hope to see you again very soon.